Dear students and friends, the topic for my class today is a bit different. It is atypical red cell antibodies. We all know about ABO antibodies, RHD antibodies, but these antibodies are a bit different. Their presence is usually unknown, they are not tested, and may result in hemolytic transfusion reactions and even in pregnancy, hemolytic disease of the fetus and newborn. So let's see what these atypical red cell antibodies are and how do they affect a pregnancy. This was my talk, which I had given in AICOG 2024 in Hyderabad. The following aspects would be dealt with: a brief introduction about atypical antibodies, then a word about red cell alloimmunization, the role of preconception counseling, screening for these antibodies, and eventually their management. Now the question arises, what are these atypical antibodies? They are also called as unexpected or irregular antibodies because their existence and type is unknown before conducting any antibody screening test. This includes most blood type antibodies except ABO and some P type. Depending on the type of antibody, they may develop naturally in patients, but most of them are formed as a part of immune response after exposure to foreign antigens during pregnancy or after a blood transfusion. These clinically significant atypical antibodies are capable of causing hemolytic transfusion reactions and in pregnancy, hemolytic disease of the fetus and newborn. Their presence always signifies that alloimmunization has occurred, which may be a result of previous pregnancy or previous transfusion or even in transplantation recipients. Hemolytic disease of fetus occurs because of transplacental passage of maternal IgG antibodies, which in turn cause immune hemolysis of fetal and neonatal red cells. Some antibodies, anti-D, anti-K, and anti-C, they cause significant fetal and neonatal risks, which include anemia and may require intrauterine or neonatal transfusion. They may even cause jaundice and at times a perinatal loss. There are many antibodies that are unlikely to significantly affect the fetus, but after birth may cause neonatal anemia and hyperbilirubinemia. Others may cause problems for screening and provision of appropriate blood or components to the mother and fetus when required. Then what red cell alloimmunization is? Hemolytic disease of fetus occurs after a woman is exposed to a mismatch of paternally derived RBC antigens from the fetus, usually via sensitizing event during pregnancy. This results in maternal generation of antibodies, which can pass through the placenta and then target the fetal RBCs, which contain such antigens and cause destruction. Over 50 RBC alloantibodies have been identified. They are present in 1 in 80 pregnant women and may cause hemolytic disease in 1 in 300 to 600 live births. Sensitizing events occurring during pregnancy are the leading cause of this alloimmunization. They may be caused by blood transfusion also, that too in pregnancy. So we obstetricians have a crucial role in risk reduction, and we must know how to identify them and what they actually are. Rhesus group of antigens on RBCs are most clinically important in obstetrics. Paternally inherited and autosomal dominant antigens they are, and they can trigger alloimmunization. Alloimmunization caused by incompatibility with Rh, D, C, E antigens can cause severe disease. Now, historically, hemolytic disease of fetus was most frequently identified to be caused by anti-D antibody. And therefore, we have anti-D immunoprophylaxis, which was discovered since 1960s. The use of anti-D immunoglobulin prenatally and immediate postnatally has caused a drop in rates of D alloimmunization to 2%. So the effect of D is now very less because of immunization. But now anti-E is the most prevalent hemolytic disease causing alloantibody. The rarer capital K and small k antigens of the KEL group can cause severe early onset anemia, even at lower levels, because they suppress erythropoiesis and cause red cell destruction. Other antibody groups capable of causing hemolytic disease include FY, JK, and MNS, parts of the NMS system. This is a chart which shows the various types of antibodies. Some of them may cause severe disease in the fetus and neonate. Some may cause severe hemolytic transfusion reactions, or both. Now, the role of cell-free fetal DNA testing. This testing from maternal blood allows non-invasive identification of antigens, the D antigen, C, capital C, E, capital E, and KEL antigens. The sensitivity and specificity for RHD genotyping is almost 100%, so it can be considered a diagnostic test. Rhesus D, C, and E are detectable from 16 weeks of gestation, and KEL is detectable from 20 weeks of gestation. Routine cell-free fetal DNA testing reduces unnecessary anti-D administration and can be cost-effective. However, there is a small risk of false negative diagnosis. So if there is a high risk of alloantibody level and that level is increasing, then we would require serial ultrasound surveillance for a sensitized pregnancy. Determination of paternal RBC antigen status and zygosity may be considered, and very rarely invasive testing like CVS or amniocentesis may be necessary for diagnostic certainty, especially if the father is heterozygous. Then, preconceptional counseling. Routine pre-pregnancy screening for red cell antibodies is not indicated. However, women with red cell antibodies, particularly if there's a risk of fetal anemia or a past history of fetal anemia or risk of compatible donor red cells for transfusion, because there is a previous transfusion reaction and red cells are not, the antibody levels have not been identified, so red cells may be difficult to obtain. These women should attend pre-pregnancy counseling. Most women who have had antibodies detected in previous pregnancy or screening prior to blood transfusion or donation has identified some antibodies. This is another indication for pre-pregnancy counseling. Women with clinically significant red cell antibodies, they always should be given information regarding the possible implications, maternal and fetal, during pregnancy. This, of course, depends on the type of antibody present. Counseling always should be by a clinician with knowledge and expertise in the condition, and in most cases, it should be a fetal medicine specialist. British Committee for Standards in Hematology, in their guideline on antibodies in pregnancy, recommends that women with clinically significant antibodies, they should always have a card giving details of the antibodies which are present. Now, screening. Antibodies to many red cell antigens have the potential to be clinically significant and will have implications in selection of blood for transfusion to avoid hemolytic transfusion reactions. Blood group and antibody status of the mother should be tested at booking and at 28 weeks of gestation. The risk of fetal anemia, we know, is greatest with anti-D, anti-C, and anti-K antibodies. Other antibodies which may cause fetal anemia include anti-E, FYA, JKA, C, and CE. There are numerous other antibodies that usually only cause mild hemolysis, that is only rarely significant. However, an alloimmunized woman in which antibodies have already been detected, they would require blood test every 4 weeks up to 28 weeks of gestation and fortnightly thereafter. So this is the chart for timing and frequency of antibody screening in pregnancy. At booking, ABO and RH typing and an antibody screen is required. If significant antibody screen is positive, then anti-D, anti-C or anti-K antibodies have been identified. Test monthly till 28 weeks. From 28 weeks, test every fortnightly. And after birth of the baby, always do a direct antigen test, a hemoglobin and bilirubin. If for all other clinically significant antibodies, consider paternal or fetal genotyping for the corresponding antigen. And if that is identified, repeat antibody screening at 28 weeks. If no antibodies are identified, repeat testing at 28 weeks and no further action is required. At any time, if significant level of antibody is detected, then go on to routine screening. The question arises, what thresholds should be used for various antibodies that could cause fetal anemia so that we may refer to a higher center or we may continue further investigation or monitoring. Now, an anti-D level between 4 international units per ml and 15 international units confers moderate risk of hemolytic disease. If it is more than 15, there is a severe risk. Referral for a fetal medicine opinion and further management can be made at levels more than 4 international units. An anti-C level between 7.5 and 20 confers moderate risk, more than 20, high risk, and referral to a fetal medicine specialist more than 7.5 international units. However, for anti-K antibodies, referral should take place once they are detected, even in low titers, because there is a tendency to cause fetal anemia. The presence of anti-E potentiates the severity of fetal anemia due to anti-C, so referral at lower levels or titers is indicated. Then, how should these pregnancies be monitored? These pregnancies in which antibody levels are there and there is a risk for fetal anemia. The cause of alloimmunization, relevant past history, and previous pregnancy outcomes should be ascertained in order to generate an assessment of risk of hemolytic disease. If the fetus carries the corresponding antigen for a maternal antibody, which is capable of causing fetal anemia, and if the antibody levels or titers rise beyond permissible levels, they should be monitored weekly by ultrasound, specifically assessing the fetal middle cerebral artery peak systolic velocity, MCA-PSV, in order to identify fetal anemia. Referral to a fetal medicine specialist for consideration of invasive treatment should take place when MCA-PSV rises about 1.5 mom threshold or if there are any other signs of anemia. Fetal monitoring is required once any level of anti-K is detected. How often should pregnant women with red cell antibodies who are at a high risk of requiring a transfusion? Transfusion may be due to obstetric indications like placenta previa or medical conditions like sickle cell disease. How often should they be tested? Pregnant women who have red cell antibodies and who are at a high risk of requiring blood transfusion should have a cross-match sample taken every week. So a new sample in lab should be there every week. Current BCSH guidelines recommend a sample of no more than 72 hours old for providing compatible blood. However, in individual cases such as high-risk women with placenta previa without red cell antibodies, where weekly samples can be taken as long as risk assessment is made and recorded in each individual case. High-risk women with red cell antibodies where sample every 72 hours is not feasible should be taken once a week, and if transfusion is required, a new sample should be taken immediately to exclude any new antibody development. However, at times there are life-threatening hemorrhages and we may require urgent transfusion. So that should not be delayed. A close liaison with the hospital transfusion lab in such cases is vital. If maternal transfusion is required, what type of donor blood or blood components should be used? Red cell components of the same ABO group and RH type and that are KEL negative and CMV negative should be selected. If ABO identical blood is not available for groups A, B, or AB, group O blood can be used. If pregnant women and women of childbearing age who are RHD negative should always receive RHD negative blood. The transfused blood should also be K negative. Antigen negative red cells should also be selected when clinically significant antibody has previously been identified but cannot be detected in most recent cross-match sample. An indirect antigen cross-match test must be used if the woman's plasma contains or has previously contained significant alloantibodies. For planned antenatal transfusions, always CMV negative blood should be used. Then the optimal mode, place, and timing of birth. Timing of delivery depends on the antibody levels and titers, the rate of rise, as well as if any fetal therapy has been required. If fetal therapy is required, then naturally refer to a higher tertiary level center where a fetal medicine specialist and services are available. The mode and timing and place of delivery is based on standard obstetric grounds. If a woman is at high risk of requiring significant amounts of blood or blood products transfused antenatally, intrapartum, or postnatally, consideration should be given to transferring her care to a center capable of processing cross-match samples and providing appropriate compatible blood rapidly. These pregnancies always should be monitored by continuous electronic fetal heart rate monitoring when they are in labor. So the management for anti-K antibodies, a titer is done. We can go for non-invasive testing, or we can test the father and identify if the fetus is at risk for hemolytic disease. Same with anti-D antibodies, a level of 4 to 15, moderate risk, more than 15, severe risk. We can go for a non-invasive test the father. Father could be homozygous or heterozygous. See if the fetus is at a risk for hemolytic disease, refer to a specialist unit, get an ultrasound done, MCA, Doppler, and intrauterine transfusion if needed, is to be delivered at 37 weeks, and after delivery, cord blood hemoglobin, bilirubin, and direct antigen test is to be done. For anti-C antibodies, quantitate the antibody level. If it is between 7.5 and 20, as I had mentioned previously, moderate risk, more than 20, severe risk. The same, if you have facilities, go for non-invasive prenatal test or test the father, whether homozygous or heterozygous, and consider the risk. The take-home message: these non-anti-D red cell antibodies are associated with hemolytic disease of fetus and newborn, and they are rare. But partly because of introduction of anti-D prophylaxis, they have been increasing in frequency. The main non-anti-D antibodies that are likely to cause fetal anemia are anti-C, anti-KEL, and anti-E. It is important to understand the unpredictable nature of KEL alloimmunization and its subsequent effects on the fetus. Increased use and availability of non-invasive approaches such as cell-free fetal DNA testing in maternal plasma and MCA-PSV Doppler assessment have reduced the need for invasive procedures. MCA-PSV Doppler assessment has now almost completely replaced amniocentesis in prediction of an anemic fetus in alloimmunization and is the primary surveillance test for these at-risk pregnancies. So we must not forget these non-anti-D red cell antibodies. Thank you all.